Thank you for kind introduction. In advance, I want to apologize because I noticed that this session is about the living donor liver transplantation a few days ago, but this topic is also can be applied to the general LT consideration. So I go with my presentation. Sepsis and active infection is an old contraindication, but is it a definite contraindication for liver transplantation? We all know this is not always an absolute contraindication, but we have to decide based on the patient situation. However, about liver transplantation in patients with infection, there's not enough data reported, so the decision is not easy to form. Let's start with the EASL guideline for infection in LC patients. EASL guideline recommend the sepsis 3 guideline and the management with sepsis with quick SOFA criteria. The concept of sepsis has been changed in the 2016 from the mere culture positivity to the concept containing life-threatening organ dysfunction evaluated by SOFA score by dysregulated host response to infection. And clinicians have to manage the sepsis patient according to the quick SOFA criteria, including the respiratory problem and altered mentality and the circulatory problem. Then let's look at the LT guidelines. Among the LT guidelines, very brief comments exist. In the AASLD guideline, they says active infection needs to be adequately treated before LT can be attempted. It's very obvious recommendation. And similar in the EASL guideline, the presence of active infection contraindicates the LT. In APA's guideline published in 2024, which many Asian experts contributed to, has a little more than about it. Controlled bacterial sepsis should be considered for LT, and the systemic or invasive bronchial infection is a contraindication for LT. However, many important definitions are still lacking, such as what is active infection before LT, and how about controlled but not yet fully treated, and what is the safe interval between treatment and liver transplantation. This study is the largest study to my knowledge, although it's a single center and retrospective study. The study compared the patient experienced pre-LT infection within 3 months before LT, and then compared with the control groups. Among the site of infection, SPP was most common, followed by UTI, pneumonia, and blood spectrum infection. Among the confirmed species, multi-drug resistant organism accounts for 38%, which is much higher than a general population. You can see the violet color is the pre-LT infection group. The post-LT infection was significantly higher than control groups. However, the post-LT survivor was similar between the pre-LT infection group and the control groups. The time from reserved or improved infection to LT is not different between the does not impact on the post-transplant outcome. And furthermore, MDR group versus non-MDR group, the post-LT outcome was similar. So then the authors concluded that pre-LT infection does not impact on post-LT survivor. However, we all know this is not always true. From the baseline characteristics of this study, median MELD score was only 17 in control group and 24 in pre-LT infection group. Furthermore, the patient with at least grade 1 ACRF was only 6% in the control group and 22% in the pre-LT infection group. So the participants was not that critically ill patients. So we can conclude that only for not critically ill patients, pre-LT infection has little impact on the post-LT survival. EASL LC guideline recommend several waiting or treatment days according to each kind of pre-LT infection, such as more than 7 days of therapy and waiting for pneumonia, and 1 or 2 weeks of therapy, and plus 2 days of negative culture for bacteremia. If the patient is not urgent for LT and not critically ill, I'm willing to follow this guideline and just wait until the infection is controlled enough to receive liver transplantation. However, the patient is very critically ill, such as ALF or ACLF, the decision is not that easy. ACLF is defined by the organ dysfunction, like liver, kidney, brain, coagulation, circulation, and respiratory failure. And the severity of ACLF was graded by the number of organ failure from 0 to grade 3. If the ACL patient has a severe infection, liver transplantation would act as a double-edged sword. New liver can treat the liver cirrhosis and then improve the ACLF after liver transplantation. However, inevitable immunosuppression and large surgical stress can worsen the infection. So, new liver function and improvement of ACLF impact more than the worsening of infection. The patient could be alive. However, the worsening of infection weighed more than the new liver function. The patient would be dead. So, this is what we have to decide more delicately for this kind of critically ill patients. Then we have to get a clue from the previous study. This ECLIPSE study is performed among 20 LT centers in European countries. They collected the data from the patient and its grade 1 ACLF patients. Their final analysis, the risk factors for post-LT mortality was MDR organism infection and higher lactate level and renal replacement therapy. They did not establish the prediction model for mortality, so actual cutoff we can use to decide whether to LT or not is not impossible. These are several mortality prediction model for LT in patients with ACLF. As you see, the infection-related factor was not included in most of model, except the UCLA futility score, which include the pre-LT septic shock. Several models included the infection-related factor in their analysis. However, they were omitted after the adjustment of organ failure. Then let's look at more detail about the SALTEM score recently published. This study, SALTEM score, was performed among the 15 LT centers in US. They included 521 ACLF 2 or 3 patients, which is the largest number ever published. They established a post-LT mortality risk score using these 5 final factors. And then they defined the futility of LT if the patient has more than 30 of SALTEM score, which means expected 1 year post-LT mortality would be over than 30%. They collected very important data, MDR bacterial infection or fungal infection. However, these 2 factors was not finally included in their model, except the MDR bacterial infection was significant only for length of stay after LT. However, in this study, they defined this infection as blood positivity before liver transplantation. So we do not know the information about whether this infection is treated or current at the time of LT. So feasibility of liver transplantation in the patient with current infection is not conclusive from this study. Anyway, from this evidence, we can know the organ failure is more important than infection itself. Then, what we can do for the patient with active infection, but urgent for LT with severe organ dysfunction. The first is broad-spectrum antibiotics, even though it's a very obvious option. EASL guidelines recommend the ACL patient And if they have a suspicion of bacterial infection, they recommend start empirical antibiotic therapy ASAP. Infection is most common precipitant for ACLF. Inadequate or delayed treatment infection could worsen ACLF. However, they did not recommend antibiotic prophylaxis because there are no evidence of that. Empirical antibiotic treatment should be tailored according to the local epidemiology, especially for multidrug resistant organism, which accounts for 34% in the global. If the patient has septic shock or there is sign of worsening of ACLF, they recommend antibiotics covering all potential pathogens should be used. They also recommend early de-escalation of antibiotics according to the cultural result to reduce the further resistant organism. Among various combination of antibiotics, meropenem plus teicoplanin would be effective treatment for covering all resistant gram-positive and gram-negative species. Invasive fungal infection could exist in 1 to 5% of AS patients and with more incidence of ACLF. Mortality would be from 94% to 60%, very high. So EASL guidelines recommend invasive fungal infection is a major contraindication for LT. Empirical antifungal therapy should be started in ACLF patient with nosocomial septic shock, and there is some risk factors such as prolonged ICU stay, severe alcoholic hepatitis, invalid catheter, EPN, and so on. Also, they recommend rapid de-escalation if the culture result is negative. Second is IV steroid. The rationale of IV steroid in septic shock is that steroid could reduce the inflammation from sepsis and improve the endocellular dysfunction and improve the hypoglycemia, then enhance the recovery from sepsis. Previous sepsis guidelines do not recommend IV steroid for all septic shock patients because of there is little evidence of that. However, recent sepsis guideline recommends IV steroid in the patient with the septic shock, and there's ongoing requirement of vasopressor. This guideline is based on this RCT published in New England Journal in 2018. 1,200 patients was divided into IV steroid group and placebo group who has a probable septic shock. IV steroid group showed higher 90-day mortality, 90-day survival, and shorter weaning days from ventilator, and shorter time to reaching SOFA score under 6. However, this IV steroid effect was not validated in the LC or LT candidate patients, so EASL ACLF guideline do not recommend routine use of IV steroid in the patient with uncontrolled bacterial infection. And the study published 10 years ago, corticosteroid increased the serious infection in the patient of severe alcoholic hepatitis. So IV steroid for the patient waiting the liver transplantation is not enough. However, I think that from general sepsis guideline, IV steroid for septic shock before LT patient would be effective because ACLF patient, most ACLF patients are at high risk of infectious death. Third is nutrition support. Nutrition support is very easy concept, but has very concrete evidence in the guideline. Both of HCRF and sepsis guideline recommend early initiation of enteral nutrition if patient is tolerable, and then they have sepsis or septic shock. If patient is not tolerable with enteral nutrition, parenteral nutrition could be used. And then the guideline also says vasopressor is not always contraindication for enteral feeding. Next is intravenous IV globulin. IVIG, there is two regimen of IVIG, polyclonal and IgM-enriched IVIG. In the guideline, they do not recommend the routine use of IVIG for the patient with sepsis or septic shock. However, recent meta-analysis showed IVIG could reduce the mortality in the patient with septic shock. However, the authors do not confirmatively comment this conclusion because the evidence is very low. I'd like to introduce this RCT, even though the volume is small. STIGMA study included 160 patients with pneumonia on ventilator. They treated the patient IVIG and compared with the placebo group. Unfortunately, in entire group, there was no difference ventilator-free days and in shorter mortality. However, in the subgroups at higher risk, such as elevated CRP and low IgM level, IVIG showed there is effect on the for reducing the shorter mortality. Of course, there's no evidence this IVIG for LT patients, but I think this treatment still holds promise. So we have to study about this topic in the future. And next is the extracorporeal blood purification treatment. Therapeutic plasma exchange is an old debating issue in the sepsis management. Recent meta-analysis showed that therapeutic plasma exchange could reduce the short-term mortality. However, the evidence is also very low. Polymyxin bidirect hemoperfusion is one kind of hemoperfusion method. It used the polymyxin cartilage, and then like hemodialysis, it can absorb the endotoxin from sepsis, like polysaccharide. However, it costs 5 million Korean won or $3,500 per one cycle. So very expensive treatment. So cost effectiveness is questionable. Another method of hemoperfusion is bioabsorbent filter. The product name is Oxiris. Oxiris could be integrated into the CRRT, so we can use it simultaneously with hemodialysis. It can remove the broad kinds of endotoxin and inflammatory cytokines. However, it's also very expensive, so cost effectiveness would be the very important problem. The evidence of hemoperfusion for sepsis was reported in several studies, RCTs, and meta-analysis, but evidence is also very low, so we need more evidence about it, especially for the patient with sepsis or severe infection waiting for liver transplantation. However, I think it still holds a promise. Last is the surgical factor. These are modifiable LT-related factors for aggravating infection after liver transplantation. Balancing waiting of improvement of infection versus the upfront liver transplantation is important, and longer operation time and transfusion by biliary antiorganostomosis, reoperation, immunosuppressant. These all factors are very important for not only for infection but also for the outcome of liver transplantation. We can modify these factors by surgery, like urgent LDLT. This is only contents for LDLT, I'm sorry. And reduce OP time and minimize bleeding and duct-to-duct anastomosis if possible, and delicate surgery to reduce the reoperation and surgical complication. And then delayed use of immunosuppressant would be the important point of LT in this population. So take-home message. Decision for LT in patient with sepsis or active infection should be made based on the ACRF, like organ failure, than infection itself. Proven or possible intervention before LT would be broad-spectrum antibiotics, IV steroid, or nutritional support. IVIG and plasma exchange and hemoperfusion is a promising treatment, but we need more evidence about it. Thank you for your attention.